Good evening and welcome to webinar number 8 in the WAVE contact lens system series. I'm Dr. Ken Mahler, and I'll be doing the lecture today on corneal GP lenses, and these are the WAVE basics to approach simple, even to complex corneas. Okay, I do know that Carver would typically mention that if you have questions, please submit them into the chat box. And they will be, hopefully, we can get him moderating it by the end of this webinar today. So I will receive those questions and I can get some answers to you. All right, without any further ado, let's go ahead and get started. First, an introduction. I do consult for both Oculus and WAVE. I am a contact lens fitter in private solo practice. My practice is basically contact lenses only, and it's really focused on irregular corneas, as well as myopia control and orthokeratology. I previously did the national clinical support for WAVE, as well as have presented formal lectures and webinars, just as this one tonight, as instruction for WAVE users. In addition to that, I do private practitioner consultation services, and I do know some of you out there have already told me that you're going to be attending tonight, so you're some of the people that actually do use some of these services, whether it's the case-by-case help, one-on-one training, the phone or in person, and the remote fitting through telemedicine. I'll get to those options a little bit at the just toward the very end of the lecture tonight. I also do beta testing for the software, both on the CSP and WAVE, as well as the AXL WAVE hardware and software from Oculus. I authored the first certified WAVE designers program, and I'm currently guiding the WAVE training so that you guys can get up to speed faster and more efficiently, so that you can get your patients taken care of properly. The schedule here, you can see we're on the third one down tonight. That's May 10th, the Corneal GP WAVE Basics. And next month, we're going to be talking about Corneal GP multifocals and how to address presbyopia, since there are so many presbyopes out there. Okay, so I decided to start with a little background foundation, just so we're kind of on the same page here. So just a very brief history of GPs. Fitting philosophies, the materials that are used. I want to compare corneal GP lenses with these other forms of correction: spectacles, soft lenses, scleral lenses, hybrid lenses, piggybacks, orthokeratology, and refractive surgery. And I also want to answer the question, who would benefit with a corneal GP lens? So let's start with the first one, GP history, and this is very, very brief. Hard lenses are 100% PMMA, that's polymethyl methacrylate. GP lenses are not, and you would do well to remember that GP lenses are not hard lenses, both from the standpoint of your thought process in presenting these options to patients. Hard just sounds bad. Really get hard out of your vocabulary unless you really are fitting a PMMA lens. Otherwise, refer to them as GP lenses. What I was getting onto now is hard lenses, when they were fit, needed a rocking motion to make certain that there was good tear exchange, to ensure proper O2 transfer underneath the lens, because basically nothing made it through the material itself. They did design change over the years from a single monocurve lens over to bicurve lenses and eventually into tricurve lenses to better approximate corneal shape. And as the O2 continued to increase, moving from the hard lenses into GPs, diameter increased as well. With the GPs, an average diameter was about 9.2 millimeters, and the question is why? They also had a reputation for discomfort and still to this day enjoy that reputation, which I might casually add, totally undeserved. The other impression from doctors is that only successful wearers really powered through that adaptation process. It was really a very, very difficult time at the beginning to deal with the discomfort that came along with GP lenses. And the only people that really made it to success were real troopers to get through the adaptation period. They're typically reserved for high cylinder, corneal irregularities, etc. And even the most diehard GP haters will still concede that the vision quality is excellent. Now let's move on now. Fitting philosophies basically broadly categorized into two different camps. The first one was a lid attached fit. And the advantages of lid attached fit is that generally it was a little bit easier on initial adaptation. We did get very good tear exchange on those. Also reduced trauma to the upper lid wiper. Induced corneal curvature changes, which is not really a positive. Glare is a positive because it would be down very low in the visual field so as to not bother the individual. And they tended to be easy to remove. The other camp was really apical alignment, where they would generally fit a little bit steeper. Initial adaptation would be a little bit tougher. There was a little reduced tear exchange, absolutely increased trauma to the upper lid wiper because the lid really needed to traverse the upper portion of the lens on every blink. However, we did get reduced corneal curvature changes induced from the lens being positioned on there, and very good vision quality because the optics was centered right onto the visual axis. Materials, broken down really into silicon acrylate, fluorosilicone acrylates, fluorosiloxane acrylate, and the siloxane acrylate. And that's true to even this day. Generally, as the O2 permeability increases, wettability decreases. Higher silicone content, you would have fantastic permeability, but the problem is that the silicone molecule is really hydrophobic, and that sticking out at the surface of the lens would really reduce the wettability properties of this lens, making it a little bit more uncomfortable. That brought about this copolymerization process to go to the fluorosilicon acrylates because it increased the hydrophilic molecular end, which helped the wettability. But by doing so there, we actually decreased the amount of oxygen transfer through the material itself. Generally, as O2 permeability increases, we would lose a bit of rigidness, or the modulus of the lens would decrease. Proper material choices is really the balancing act of getting the O2 permeability that that particular eye needs, proper wettability that the tear film and the ocular surface can support, as well as machinability from the lab standpoint, durability from the patient handling and wearing point, flexure resistance to make sure that vision remains good, as well as warpage resistance so that the lens does last over some time. Now, comparing corneal GP lenses with these, this list of other optical corrections, I want to talk about vision quality. We can all talk about any of these options as correcting ametropias and providing vision for the patients. But generally speaking, and as I said before, even the haters of GP lenses would acknowledge the fact that corneal GP lenses seem to reign up at the top of the vision quality that they could provide for the patients. They definitely would beat out spectacles and soft lenses. Many patients, many of the doctors are under the impression scleral lenses are superior to corneal GP lenses, and that actually isn't the case. I've done several side-by-side comparisons with patients in my own office that I've been fitting with scleral lenses for a couple of decades now. And the big if here is if you can get a corneal GP lens to position correctly, it will generally outperform the optics of a scleral lens. For the other options there, it's clear that the corneal GP lenses win out in terms of vision quality. For ocular health, who really wins out the best here? Well, probably spectacles, since they don't do anything to the surface of the eye. But once we get a contact lens on the eye, once again, corneal GP lenses really do reign at the top of ocular health. We still do have many unknowns with scleral lenses. Hybrid lenses have their own issues in terms of both fitting as well as oxygen transfer, in terms of warpage of corneas and the like. Piggyback lenses, well, clearly that would be worse than the GPs, because you now have a soft lens which can act as a great reservoir for bacteria, as well as also decreases the amount of oxygen getting through to the cornea. All right, what about comfort? Well, this is where corneal GP lenses seem to fall right by the wayside. And that really has been the single biggest problem that corneal GP lenses have had in practitioners using them as a sort of go-to modality. What about the economics? Well, actually, if you take a look at everything on this list over here, the corneal GP lenses actually reign at the top over here in terms of economics. So from a patient's pocketbook standpoint, corneal GP lenses are actually very, very desirable. And as far as handling and maintenance, the handling absolutely is much easier with a GP lens than virtually everything on here except the spectacles. And as far as the maintenance, once again, except I might concede the daily disposable soft lens, which has no maintenance, everything else on here requires a bit more maintenance than a corneal GP lens. All right, so who would benefit from a corneal GP lens if we could just put comfort to the side for just a moment to have a good discussion on this? Well, the irregular cornea, certainly disease, keratoconics, herpetic sequelae, corneal transplants, traumatic injuries. This has really been the mainstay population that's been put into corneal GP lenses historically. What about normal corneas? Well, the only ones who tend to really end up in corneal GP lenses that have normal corneas, they have high myopia, high cylinder, or possibly the cylinder is at oblique axes. And that's certainly a place where soft torics have a very, very difficult time performing solidly for the patients. But how about any or every normal cornea that walks into your chair? The 20-year-old two-diopter myope, for instance, who has nothing wrong with them. Would that person be someone that would benefit from a corneal GP lens? I would argue yes, that they would. Hyperopia? Well, hyperopia is a little tougher because you have the plus, which increases the center of gravity and the weight of the lens further forward, which possibly has the lens fall. So it's a little tougher to position. But I would still submit that hyperopes can benefit tremendously. And as far as presbyope and multifocals go, gosh, this is a godsend. This lens can really outperform virtually everything else on the market for the presbyopic market. So this is a fantastic device for the presbyope. All right, so fitting any or every cornea into a corneal GP lens requires a change of perspective for the doctor. And I'll never forget, this was going back quite a number of years. I had a consult for a doctor who sent in a case. I did the case, I sent back lenses, and then I received the single complaint from the doctor saying that the patient had a GP look when I was looking at them after putting the lens on their eyes. And I just had to follow that up to what's exactly a GP look. And so he answered me with, you know, where they can't open their eyes and tears are rolling down their face and they clearly are miserable and would prefer to be anyplace else. And I really had to correct him and say, that's not a GP look. That's the look of a patient who has a lens that doesn't fit well on the eye. That has nothing to do with GP lenses. If GP lenses are fit properly, they do not have that look. So it really does require a change of perspective, because if you're going into it thinking that that's normal, that's already sabotaging your efforts at getting a successful lens on this patient. A corneal GP lens should really not be thought as the last option when everything else fails and the patient has criteria that can't be addressed by any other means. Rather, think of the corneal GP as a superior option that outperforms virtually every other optical correction in almost every given situation. They're fantastic devices. There are a few situations, however, that are relative contraindications to this thought process. The first one is tear film is compromised or you have ocular surface disease. When you have a tear film that's compromised, you may not have enough tear film to support that lens properly. And so that may be a bit of a problem. That being said, I have many patients, both with compromised tear films, ocular surface disease, doing very well and well all day long in their corneal GP lenses. So it's not impossible, but that certainly is a little bit tougher situation to deal with. Corneal elevation extremes, that means the peak and the valleys on that particular cornea are greater than 350 microns. About 7 or 8 years ago, there was a study out of Pacific that showed if you have elevations that are greater than 350 microns, that tends to be a little bit tougher for a corneal GP lens to perform on properly. But however, if you are sort of stringent and take a look at the elevation on your topography and it's less than 350 microns, 88.2% of those patients were successful in corneal GP lenses. That's 9 out of 10 people. That's a very, very high success rate. And I encourage you next time to take a look at the next keratoconic cornea that you do a topography on. 350 microns is an enormous amount of deviation from the highest peak to the lowest valley on many, many of the keratoconics. So many of them really can be successfully fit into a corneal GP successfully. And of course, the normal cornea certainly could be fit into that lens successfully. Posterior corneal irregularity is neutralized by the anterior cornea. There are a couple of optical instances where you have a very, very irregular anterior surface, and as luck would have it, the posterior surface is sort of irregular in the same direction, and it allows a certain neutralization by the back surface of the lens of all that front surface irregularity. When that happens, if you put a corneal GP lens on that eye, or for that matter, even a scleral rigid lens, you will have a very difficult time providing a vision result that's satisfactory to that patient. And oftentimes, practitioners are surprised where the cornea is fairly irregular, but it's irregular on both the front and back surfaces, and they're getting reasonably decent vision out of a pair of spectacles, let's say 20/30 or so. You go ahead and put on a gas perm lens thinking that this would be, something that would get this eye down to 20/20, and lo and behold, it's stuck at 20/50, whether it's a corneal GP or a scleral GP. And the reason has to do with this matching of the irregularities by the posterior and anterior surface cornea. Exposure to airborne debris. So if you're thinking about the person who hangs sheetrock all day long, that's a person who's going to have a tough time with a corneal GP because you will be getting a lot of debris underneath that lens. So any place where you have a patient that's exposed to a lot of airborne debris, this is a real tough situation for a corneal GP to perform well in. All right, so let's get to an overall fitting approach using WAVE. So traditional corneal GP fitting, we would determine the diameter, the base curve, the optic zone, both the front and the back surfaces of that particular lens. We might define up an intermediate curve radius and width, a peripheral curve radius and width. We may even put on more than 3 curves. The material rigidity, we would specify that, trying to get proper oxygen, wettability, considering the specific gravity, such as I was talking about with the hyperopes. You have to be sensitive to the fact that those lenses tend to be heavier. Edge treatments to try and make them a little bit more comfortable. Maybe some blends or aspheric curves on the back of the lens to make it approximate the cornea a little bit better. Put in some toricity, both centrally as well as peripherally. Maybe even get into a quadrant-specific type of a design. Possibly putting in prism to balance out the orientation of the lens, and then specify maybe the center and edge thickness. Well, you look at this list, and boy, that's a lot of specifications that we're trying to customize this lens to this particular eye. So the question is, why are they so notoriously comfortable if we took the time to make all of these wonderful design parameters appropriate for the particular patient we're taking care of? So let's take a look at this particular eye. I think we would agree this is an average normal cornea. It's boringly normal. We take a look, we see the Ks are about 45 by 45, 50, so about a half an octave with the rule cylinder. The H5D is 11.3, so it's just a little bit on the smaller side, and there's a small pupil. But I think we would agree that the distribution of the curves on this particular cornea are certainly very, very regular. So let's take a look and see exactly what the problems are. Here at the nasal curvature, you can see I've gone ahead and I've put the cursor down, and we have a curvature of 3873 diopters of curvature. I'm just talking in terms of keratometry readings because people don't tend to think in terms of millimeters as easily. So we have 38.73 diopters of curvature on that nasal side at a chord of 7 millimeters. If we then move up to the superior curvature at 7 millimeters, we see that the curvature there is 43.25 diopters. And then if we move over to the temporal side at a chord of 7 millimeters, we see that the curvature is about 42.5 diopters. So to summarize, we have on the nasal side at a chord of 7 millimeters there, 38.75 diopter of curvature. Superiorly, we have 43.25 diopters of curvature, and temporally we have 42.5 diopters of curvature. The average back optic zone on a standard gas perm lens is about 7.5 to 8.0 millimeters, which means that on this chord of 7 millimeters, we have a difference there of from 38.75 to 43.25 diopters of curvature difference that you're going to address by a single base curve. Well, do you see a problem here? We have a really strong mismatch between the corneal curvature, which is showing a difference there of what is that, almost 5 diopters difference in curvature, and you're fitting a traditional GP lens with a single curve to address all of that. And actually even a little bit further out where the cornea is actually getting a little bit more different in the different quadrants. So Wave Corneal GP fitting. Wave provides the designer much more control, and we can deal with things like this asymmetry that was on that very boringly normal cornea that we just saw a moment ago. Now that we have all this control, what do we want to do with it all? Are you a little confused about which way to go? Well, that's typical of the new Wave user. They take a look on the screen and they're not really sure what things they need to address. And this is a case of where if you don't know what you're doing, all of that ignorance in terms of what the program is actually incorporating into the Wave can really come back and haunt you and really create a design that does not work at all. So in addition to knowing what to do, we also really have to sort of change the goal that has been typically utilized with the traditional GP lens. And the reason for that is that the traditional GP lens had to deal with the fact that it was not able to deal with that level of asymmetry. Even on normal corneas that have asymmetry, you would try and squeeze all that into a single curve. And that's a real problem. So with the Wave lens, we probably should be changing our goal with our design, since we can, and we can probably create a better fitting relationship. So what's the new target goal for a Wave GP lens? I've broken it down to 3 magic rules to successful Wave GP lens fitting. So here's a Wave lens, and you can see the cornea down at the bottom, and that cornea has a little bit of cylinder, and that's the lens that's up on the top that I had designed for this particular eye. And the first magic rule is alignment. We really want to get the lens to align with that cornea. The second rule is alignment. Make certain you get this lens to align. And the third rule is alignment. It's a very easy set of rules to remember. We're just trying to get the lens to align to the cornea. If we can get the lens to align to the cornea, think of this as you have now created a GP lens out of rigid material that contours to the shape of that underlying cornea, just like a soft lens would drape on an eye. It's really no different than that. So if we can get this lens to align so well, we really can achieve many goals that we're not able to even be approached or even thought of with that traditional tri-curve lens. So what would a well-aligned lens do for you? Well, it'll center very well because it's very well aligned. It's going to find the place that it has the greatest relationship with the cornea is dead center, because that's how you've designed it. It limits the amount of movement of the lens. Of course, the lens isn't going to move anywhere because as soon as it moves off center, you now have a mismatch of curves that now push it back onto center. There's much less disruption to the tear film. We also have way less chance of a lens coming out. In fact, if the lens is really contoured very well, that's probably one of the biggest problems, is figuring out how to get the lens off the eye, because it's actually very stable sitting right there centered on that eye. Better physiology, absolutely. You will achieve a much better physiologic result with that lens and that particular cornea. Minimal corneal changes. If the lens is aligned with this particular cornea, it has no reason to start pushing corneal tissue around. Additionally, if you've created a physiologic result that's really very, very good for that particular cornea, you really are not going to create any metabolic warpage as well on that cornea. So we really don't see a lot of changes to the cornea. And in fact, that's actually one of the things that I use sort of as my report card. When I go ahead and fit a corneal GP lens and I have the topography that I'll take after the person's been wearing the lens, I expect that topography to look pretty much like the topography was when I fit the lens. I don't expect to see much change at all. Even bearing, meaning that it's really well supported throughout the entire dimension of the back of the lens, means no binding. There's no real hot spots or places where the lens is going to sort of dig into the cornea and find itself bound. You also eliminate that whole seesaw principle that we needed to do with hard lenses, and which created that rocking, which got the tear film to bring oxygen back to the cornea because you couldn't get it through the lens. Well, we have some fantastic materials now that breathe very well. We don't really need that seesaw principle any longer. Best optics, hands down, because the lens not only is well positioned over the visual axis, but it's not moving around a whole bunch. It's a very, very stable platform. And so you don't get a lot of deviation even with the blink. Patient comfort, which is the biggie that tends to be pushing GPs down to the list of what would I like to fit this patient into. Absolutely, by getting this lens aligned and getting all of these benefits above, you absolutely will improve the patient's comfort. So let's take a look. This was actually a case I had done through consult. So this is not my video, so I apologize for the sort of the movement of the video, but let's take a look at the video. And this is a wave lens that I designed for this particular doctor. And I want you to take notice of the position of the lens, the movement of the lens, and in just a moment we're going to see the fluorescein pattern. So I want you to take a little time to assess that fluorescein pattern and see what you think. Yes, the lens does need a little bit of a cleaning there. They had a little bit of debris on the lens. Here's the fluorescein pattern. And yes, it would have been helpful if a Ratten filter was used, but I still think you can see enough about the fluorescein pattern on this particular lens. Okay, let's move on to the next slide. So what do we notice in this video? Where was it positioning? Well, it was positioned beautifully dead center. How about the movement? There was very little movement. As a matter of fact, I would say the movement of that lens on the blink rivaled any soft lens that you would typically put on an eye. If not, maybe even less than a soft lens would move. What about the sodium fluorescein pattern? Well, it looked really very, very even. So now, since WAVE is a modeling system, what do we need to create this type of alignment fitting relationship? When we look at that WAVE interface screen, how do we look at that screen and figure out how we can get that type of a result? So here's the WAVE interface screen, and how do we go about getting that result that we just saw for that particular lens? Well, step one, this assessment is of vital importance to design within WAVE, and it's so important, and I don't think many people really give a lot of thought to this. Comparison of the topography with the WAVE representation of the cornea. Let me say that again. You need to compare the topography with what WAVE thinks the cornea looks like when it represents the cornea. So Here we have the topography on the left, and on the right, that's Wave's interpretation of the cornea. And you need to take a look at both of these colored maps and decide how good of a job is Wave representing this particular cornea. This is really what sets the stage for the green line, black line relationship that you see on the Wave screen. So if these two look alike, which I would argue in this particular case, they're similar, but they're certainly not alike. Certainly on the topography, we can see along the horizontal meridian that this lens flattens out well within the pupil. It's almost, I don't have the grid on there, but it's probably within the first millimeter away from dead center. This is already flattening out. Whereas if we look at the Wave representation along the horizontal, you really don't see that same flattening out. Furthermore, the astigmatism that seems to be readily apparent, that with the rule astigmatism on the topography, there's a little red blip dead center on the Wave screen. And so it's really not capturing the level of astigmatism that is really being shown on that topography. Now, if you look on the lower right, you can see that Wave knows there's 2.5 diopters of with the rule cylinder here. But as far as the picture goes, the picture's not really representing it like the topography is. And so that is going to change a little bit of the representation that you see on the screen when you're trying to align the black line to the green line. Just a word about these colors that we see creating these particular maps. They are maps throughout the Wave displays. And the colors represent ranges, not single values. So bear in mind that if you're at the top edge of one of the ranges, that could also be pushed to the very next color up, but the lowest end of the higher range. So they're not single values, so you really do have to sort of appreciate the fact that you have this real range that's lost within any particular single color. Between 37 diopters and 49 diopters, the range is 1.5 diopters for each color. And 1.5 diopters is a lot if you think about trying to fit a 0.5 diopter steeper or a diopter steeper or even a 1.25 steeper. Remember, the cornea is not, and the Wave screen isn't going to look any different. It's the same exact color, yet those fitting relationships are very different. Past the 37 diopters on the flat side and the 49 diopters on the steep side, the range actually increases for each color. So you actually have a greater step value to get from one color to the next. So this here happens to have been on the Scout topographer. This here is on the Pentacam. And I think you would see that they have very, very good agreement in terms of their overall color distribution. Let's see how Wave did with that. Well, if we take a look there, we could see down in the lower left, which is the Wave's interpretation of what this cornea looks like. It looks very much like both the Scout and the Pentacam maps. As a matter of fact, I don't think you can tell from that Wave representation of the cornea which one of these topography datas I actually fed in to create that particular map, because they do look so similar. When you have that type of correlation, you can really bank on the Wave screen as being a fantastic modeling of that particular cornea, and you can be assured of a much more trustworthy relationship that you're going to be creating between the black and green line. Okay, so let's take a look here. The three zones that I break up the corneal GP lens into are the central zone. And that's kind of all within the red balls. From the red ball on the one side to the other, everything inside there, that's all about vision. That's where you're addressing the vision issues of the particular patient, because it's directly over the visual axis. You then have the area that's right outside that, which really includes just inside the red ball, but also out to, but not including where the pink ball is. And that really is going to describe where the lens is going to position. So that really is controlling the positioning of the lens. And then this very outside area between the pink and black ball, that's all about what the patient is going to feel. So if you take a look at those first two ovals, regardless of what you do there in terms of creating alignment, that has nothing to do with what the patient is complaining about if they're telling you it's uncomfortable. The place that they're talking about is out here, unless there's something grossly wrong with those central areas. All right, so let's take a look at this particular lens. Here along the 0 and 180 degree meridian, take a look at that line graph down at the bottom there. And here we have the blue line versus the green line. And you'll notice at the 20 micron line of the tear film that my blue line is pretty much hovering right around the 20 micron line. It just pops up a hair above that, maybe to about 23, 24 microns, just about where the red ball is. Now, if you think about this in practical terms, understand you need about 20 microns to see fluorescein at the slit lamp. So what would this lens look like on the entire left side? It would look like it's black. You wouldn't see any fluorescein. And if we looked on the right-hand side, on that nasal side there, we would get our first hints of fluorescein. And if you take a look at the upper portion here, where it's being represented by the fluorescein map, you can see that's exactly what wave is representing. There's just a very, very subtle hint of fluorescein showing up over there on that nasal side. Let's move on. Here's on 45 to 225, and the map looks virtually the same. If we look at that blue line, green line representation there, they're virtually the same. It's probably about one micron higher, maybe 25 microns, 26 microns. So again, we're hanging really at the 20 micron line or below. How about superior and inferior? Well, once again, we can see here that the high point there, you probably, I don't know, 23 microns or so. So once again, very, very well aligned. And then what about on the 135, 315? Well, this one here is probably even the closest. It's probably down around 21 microns of clearance, and everything else is below the 20 micron line. So we have very, very good alignment with this lens and this particular cornea. So let's take a look once again at this particular video. And with that in mind, thinking about the positioning of this lens, look at how beautifully centered this lens is, and take a look at the movement on the blink. You could see almost a barely a deflection of the lens. You see the tear film drape over the lens there with the debris on it, but the lens itself, not a whole lot of movement. Look at the fluorescein. The only place we're really seeing fluorescein is that subtle green glow centrally, particularly superiorly, and then out at the periphery where I've lifted the lens up to create the peripheral tear pool. That's it. The rest of it really looks very, very well aligned. So now let's move on. Better aligned GP fitting with lens, with wave. This here was taken from webinar 2. So if you're interested in the actual case, by all means, go back to webinar 2 and take a look at it. But on the left-hand side there, what you're seeing there is soft lens corneal warpage. Soft lenses do a whole lot to corneas. If you take topographies on every soft lens wearer, you'd be amazed at how much they really do induce corneal changes. Now, on the right-hand side over here, this is a patient that I went ahead and refit into a corneal GP lens. And on the top, you're seeing the right and left eye there. That's a wave multifocal immediately after removal. And she'd already been in this for 2 years. Down on the bottom, that's 9 years later. And again, I've taken these topographies. They come into the office. I'll take acuities. I'll take a look at the lens on the eye. I take the lens off the eye and take topography. There was probably no more than 5 minutes between the time I removed that lens and the time these topographies were taken. And so here's a case where the soft lens did a whole lot of warpage to a cornea, and my corneal GP lens does not. These are the actual lenses that I fit on that particular woman. And she has been wearing this for, like I said, about 9 years now. And again, they're GSIM lenses, 11.5 millimeter diameters. Her power is 775 and 8 1/4. And the ad has changed over the years. And I think right now she's up to about a 2, maybe a 2 1/4 ad or so. I don't remember exactly. She actually was just in about a month ago. All right, let's go to the next one. This beautiful cornea was courtesy of LASIK. That was a LASIK mishap, and it cut a real mess into that particular eye. And on the left-hand side, that's how this patient presented to me. No lens wear whatsoever, but very unhappy with their LASIK result because they really didn't see very well. On the right-hand side, that's the topography after I took the lens off, 1.5 years of wear with my corneal lens. And I think you can take a look and see that, like I was talking about earlier, I kind of use this as my report card. I want to leave the cornea pretty much as I found it. And you take a look at these topographies and you can see here, they do look very, very similar. This is the actual lens I designed. And if you do take a look over here, once again, comparing the corneal topography with Wave's interpretation of the topography with what I actually designed into the lens here on the back curvature. This was post-LASIK. I did use a freeform design so I can create that asymmetry that I had to deal with all of those curves from the miscut flap. It's an 11.5 millimeter lens and power is about 6.25. This eye did get to 20/20. I was very happy with the results of this lens. Okay, this here was a post-hyperopic LASIK patient that was put into GP wear because he was not happy with his results, and he came in with about 20/30 minus acuity with the GP lens. His maximum wear time is about 8 hours because he toughs it out. He's not very comfortable with the lens, which is how he got to me. And he's been in this lens for about 6 months, and he was looking really for something better because he really wasn't happy with the vision, as well as he really was very unhappy with the discomfort. So I talked to him about coming out of that lens so I can get an idea what the cornea actually looked like. And the way I did that was I actually fit his other eye first, and then we took him out of this eye. This dropped to 2400. You could see that the hyperopic LASIK is a bit more apparent now. And this was after only 3 weeks of discontinuing wear. So I'm sure that that actually isn't a normal eye yet. It's just more normalized from the apparent abuse that the previous GP lens was doing to this cornea. So I went ahead and refit him. He gets about 16 hours of lens wear with his corneal GP. This eye, he gets 20/15 acuity with his GP lens. And that actually brings up another very interesting point. The 20/15 acuity with the GP lens I designed for him versus the 20/30 minus acuity with the GP lens he came in wearing. There's sort of this unwritten rule out there that, you know, if you have an irregular cornea, just go ahead and put virtually any corneal GP lens on so you can get some idea of the potential for vision. I would argue that does not tell you the potential for vision. It tells you the least amount of improvement that you would get in vision. Because here, this GP lens that he came in wearing really only gave him about 20/30 minus acuity. Whereas once I had a proper fitting lens on him, he was at 20/15 in this eye. He was very comfortable. He had been wearing, at the time of this map, he had been wearing the lens for about 2 years. And again, I took this immediately upon removal. If we take a look at the design, this was the design that I had designed for him. Once again, you can see here, here's the corneal topography that I designed from, which did look very much like that topography we saw. And here's the actual design that I had put into the lens on the back surface here. Take a look at my blue line, green line, and you can see there that we really do have a very, very nice aligned relationship. Post LASIK, it's a G-SIM lens, 11.5 millimeters. The script I have in there is a +50 -350 axis 120. Okay, let's take a look at this one. This one here is an RKI. This particular patient traveled in to see me from across the country because she had already tried many different scleral lenses and had failed in all of them. And in fact, her email to me when she first introduced herself was, I had RK surgery, I failed with every scleral lens I've tried, what am I supposed to do now? And so I spoke with her, I had her send me some maps. I said, well, I think I can get a corneal GP lens on you and you'll do fine. So she decided to come and make the trip, and here's the pair of lenses that I had designed for her and her RK eyes. Freeform, 11.5 millimeters on the right. She's about a -550. Yes, she's minus. She had been a very, very high myope prior to her RK surgery, and she never really quite got down to plano, but instead of the typical hyperopic sequelae that you would expect from an RK eye, she actually receded back and is now actually fairly myopic, although not as myopic as she was prior to her RK surgery, which I think was about a -11. Here's 775 on the left with 1.5 diopters a cylinder. But take a look at the bottom graph over there, and you can see there, particularly on the excuse me, on the right eye, a very, very nicely aligned profile. The left eye, we had a little bit tougher time getting it aligned, and that's even on the 140 scale. So we are up about 40 microns, but again, 50 microns, that's not a ton of clearance. Lastly, here's a new patient that was very normal set of corneas, and nothing unusual about her. And I decided to go ahead and fit her into an RSIM lens, 11.5 millimeters, 5.25 with 2 diopters a cylinder, 375 and 170 cylinder, and these are a pair of multifocals as well. She was actually just in last week, and she gets about 20/20 minus in the distance, where I will point out she gets about 20/25 minus with her spectacles, best corrected. So 20/20 minus in the distance with her multifocals is wonderful, and she's thrilled with that. And she is reading a J1 with the multifocal there as well. So that concludes our discussion tonight about corneal GP lenses. Down in the lower right there, that's the web address for my consultation services. And I'm just going to go through that briefly here. There are 5 options that you can get me to help you out with. And it primarily is aimed at more advanced learning, off FDA type of approvals, much more complex designs, and definitely beyond the Waves help desk. So we can do a case-by-case help. That's where a case comes in and either it went off the rails for you or you just think it's way beyond you to start with. I can do the case for you or bail you out, and then you can learn as we go on that particular case, and all the while getting your patient successful. Phone help is based on time units, and typically it's targeted learning for more specific types of topics or specific cases, or to bail out a specific case. It's not so much a generalized type of learning venue. The one-on-one personal time, that's where we will block off a day or even 2 full days targeting very specific weaknesses that you have, as well as the goals that you're specifically trying to achieve. For example, you want to do the very, very best and learn everything there is to know about orthokeratology. We will spend 1 day or 2 full days only talking orthokeratology and nothing else but orthokeratology. Design and supply, that applies primarily to non-Wave users, where I will design lenses for them and supply them with the lenses. And then the DVDs, that's from the Wave Winter Weekend Workshop I had done a few years back. And it really is a very good smattering of topics. It's 16 hours of lecture that I went over really many theoretical concepts, clinical applications, design, study data on virtually everything that you would possibly want to design for with Wave. Ortho-K, Scleral lenses, regular corneas, multifocals, no matter what, I kind of covered it all. So it was a very, very good overview. Lastly, we have the Wave contactlenses.com page that's from Wave itself, that provides clinical support as well as the concierge lens order services. There's the Wave Academy, where these videos do end up online. It offers technical support, as well as you can get the IOs from there, and the user guide, obviously, to utilize anything that you may not understand how it works in Wave. Then there's the resources page, which really has open access. And then the Wave users group, Google group, where we all will get on and discuss various topics. You run into something specific that's giving you reason for pause in your practice, or a specific case or whatever, you can pose that out to the group, and people will jump in and typically help out.
All right, ready for the first question?
Yes, sir. Okay.
How do you determine what diameter lens you're going to use for a corneal GP?
That's actually fairly easy. I find it easy. The first thing is, what type of corneal GP are you fitting? If it's for day wearing use, generally 0.5 to 0.6 millimeters smaller than the horizontal visible iris diameter. So for example, if you have an 11.7 cornea, I might fit an 11.1 or 11.2 lens. And the reason for that is because we can really contour the periphery of the wave lens to really address that peripheral corneal asymmetry that was not possible to deal with traditional tricurve, quadricurve, pentacurve lenses before. And so going larger really does help stabilize the lens, and the fact that we can contour it to the particular cornea allows us to create a proper relationship, so the lens is going to perform very, very well. Now, the only exception to that is an existing corneal GP lens wearer. You must take into account the size of the lens that they've come in with their presentation. So for example, let's take that 11.7 millimeter cornea, but they came in wearing a 9.2 millimeter lens. You will be in for nothing but heartache if you fit them into an 11.1 or 11.2 lens, starting with the very fact that they can't get the lens off their eye. But additionally to that, their cornea and ocular grounds are very, very different from wearing lenses for so many years. And so typically I will try to stay either around the size that they came in at their presentation, or if I have a reason to go bigger, the absolute largest I will go is the midpoint between what I would have done had they been a virginal wearer and the size of their lens. So for example, on my 11.7 cornea, I would typically, on a virginal eye, maybe fit an 11.2. They came in wearing a 9.2. I would not go larger than 10.2 for the very first lens. But like I said, I will typically stay somewhere around where their size is.
You know, a fairly straightforward procedure with a lot of good reasoning behind it. You talked a lot about how to determine whether you're going to have a good outcome in terms of like the alignment and the topography matching what's showing up in wave. What do you do when it's not matching?
Well, you have really only two options. The first option is go back and get better topography, because it's possible that your topography is awful, and that's the reason why they don't match. The second is you can't really get any better topography. That's as good as it gets, and for whatever reason, it seems to be changing rather dramatically when it goes into wave. Then you have to really appreciate the fact that the wave screen is putting down a template in that green line that's a lie. It's not really telling you the true shape of that eye, and so that's going to require a bit more finesse in trying to take a look at the topography and then going to your wave screen and possibly design something that doesn't look so pretty. And in fact, it can even get quite ugly. I know I often will get back very interesting comments from doctors that I've done lenses for, and they'll take a look at the line graph representing the lens, and on the left-hand side, it's off the screen, and on the right-hand side, it seems like it's banging into the cornea. And they'll say, really, that's what you want me to order? And the reason is because I've gone ahead through the troubleshooting. The green line reference is incorrect, and if it's incorrect, you can't trust what you're seeing on the screen there. So that's sort of like more level 2 type of fitting. Definitely, if you're newer to wave, you really want to start by getting the screen to at least represent as close to reality as possible what's truly going on that cornea, so that you can design a lens and make certain that your design choices make good coherent sense, given the fact that that's a very good representation of the cornea inside wave.
Absolutely. That's definitely, probably more complex than a lot of people will get into just starting out, but still good advice as, people get more experience fitting corneal GPs. All right. Do you ever use dots or lines to track the alignment, your magic rule of three? Do you ever use, dots or that, or do you just use the um, fluorescein image and the just slit lamp examination of how the lens is fitting, like any movement in the
I
slit?
will only use really the dots and lines, and I personally don't have lines accessible to me because I'm using Metro and they don't have the ability to do lines. So I just use dots. But the only time I really use the dot is not to assess the alignment. It's really to assess the rotational stability of a front toric lens when I have front cylinder, because I want to make certain it's lining up correctly. Now, there are a couple of exceptions to that where I have put a dot on a lens, and particularly when I'm dealing with enormous amounts of asymmetry, such as with a scleral lens, and sometimes there could be a millimeter difference between the sagittal depth of the superior and inferior area there, and I want to make certain that the lens is lining up properly. But that would probably be the only exception to that rule. I really do rely very, very heavily on the fluorescein pattern at the biomicroscope, because the if the cornea is looking back at you and the lens was made exactly like you told the lab to make the lens, the fluorescein never lies about the relationship between the front of that cornea and the back of that lens. And so I trust that implicitly, although, like I said, less than 20 microns, you can't even see fluorescein. But again, if it's less than 20 microns, that means I'm probably somewhere in the alignment area. If I'm seeing loads and loads of fluorescein, that means clearly I have a lot of clearance somewhere. So I really do trust the fluorescein pattern much more implicitly to achieve that alignment that I'm looking for, rather than the dots or lines, although that probably would help. So I don't think that there's anything wrong with that. I just don't particularly do it.
Makes perfect sense. For those people without a pentacam, how do you determine or predict whether the back surface is actually going to be a contraindication for a GP?
Good luck. The probably the only tip-off, if you don't have a pentacam or anything else that can give you rear surface information, is the tip-off is going to be that they have surprisingly good acuity in spectacles or soft lenses, given the fact that the front is very irregular. That would really be the only tip-off. And in fact, I remember there was I don't remember if it was a study that was published or something like that, that I remembered reading a couple of years ago about if a keratoconic patient comes in and they have spectacle acuity of about 20/30, even though the cornea really looks fairly messy, and you wouldn't expect to be able to get a 20/30 acuity out of that particular cornea with a pair of spectacles, be very, very leery about trying to put them into a scleral lens, because typically you will fail. And the reason you fail is exactly that issue, that the rear surface was not taken into account. You neutralized out the front surface, and in fact gave considerably worse vision than you were expecting. So, like I said, the tip-off would be unusually good levels of acuity with spectacles or soft lenses, much more so than you would expect when you take a look at the interior surface of the cornea on the topography.
Perfect. On kind of that same idea of contraindications, you mentioned dry eye or ocular surface disease is a contraindication. How can you successfully fit a dry eye patient in corneal lenses or corneal GPs?
Well, just to correct, I didn't say a contraindication. I said a relative contraindication, meaning that you should really take pause. And on some of those cases, the dry eye can really be managed before you start fitting the patient into a corneal lens. And by the way, that goes for ortho-K as well. And so, if you have a topography, or you've done even mybography and you've seen that you really have a compromised tear film, before fitting really any lens, you really should try to address the tear film problems and or the ocular surface disease, because it's going to make any contact lens more difficult to fit. And by the way, including even scleral lenses. Scleral lenses don't fix any dry eye problems. They just move the dry eye problem to the front of the scleral lens. So the cornea is happier, but that doesn't mean that your patient's going to be happier. So the dryness issue really is the bane of the contact lens fitter's existence. And corneal GPs are not an exception to that, although they tend to do a little better than soft lenses will. But as far as how are you going to predict success, that's really very, very challenging at the beginning. You would have had to have fit enough lenses on enough eyes to see exactly what's going to transpire between that lens and that particular tear film to know if what you're going to do is going to be disruptive enough that that person's going to be continually uncomfortable with the lens. And that's really where it all comes down to. Now, that being said, I've had many patients who have reported over the years with significant dry eye complaints. And I take a look and I say, you know, on my side, that eye doesn't look that bad. And again, what's that bad? It's just experience looking at tear films that have been compromised. But it didn't look that bad to me. And I said, you know, I don't think that that's going to be a problem for us getting a corneal GP lens on. And sure enough, I'll proceed and I'm successful. If you see tear frothing, you know, that's going to be a problem. It doesn't matter what lens you put on there, that's going to be a problem. If you see very, very quick breakup times, that's going to be a problem. So those are the types of things that you really need to be on the lookout. Tear breakup time looks fairly normal. The meibomian glands don't look that terrible. The lid margin is not that awful. It's not like that eye that you can see the blepharitis from across the room when the patient walks into the room. You know, those are the types of things that need to give you pause. And like I said, step one is really to try and resolve some of those things before you even go ahead and even think about it, lens fitting, regardless of the type of lens.
Perfect. That makes total sense. Even as much as people kind of hate treating dry eye due to a lot of the intricacies of it, it can still be a very important step in fitting a contact lens. All right, unfortunately, that is all the time we have for tonight. Thank you so much, Dr. Mahler, for that wonderful presentation. I want to thank everyone for watching and submitting your questions. For those questions we didn't get to tonight, which are quite a few, we'll have the opportunity to try and answer some of them offline, or we might even take the time to include them as part of the subjects of discussion for the future presentations. So I hope you all have a wonderful night. Dr. Mahler, any final words?
No, thank you all for coming out tonight to listen to the webinar. I'm glad that there is interest in GP corneal fitting. It makes me feel wonderful about it. And Carver, if in fact there are enough questions about this, I certainly do not mind doing another corneal GP lecture, maybe to expand out on some of what I hit on tonight, depending on the level and complexity of some of those questions. So we'll take a look at those and see maybe that's material for an entire webinar.
Absolutely. Have a good night, everyone.
Have a great night, all. Good night.